And now we get to the heart of this form. Two comparative studies that together analyze 23 national responses to COVID-19, undertaken by 78 researchers from 47 institutions around the world. Please welcome to the stage 5 of the principal investigators who have overseen this extraordinary collaboration. Professors Sheila Jasanoff, Stephen Hilgartner, Wilmot James, Lyle White, and Larry Stanberry.
Thank you, Chris. I'm Sheila Jasanoff from Harvard University, one of the PIs on this pair of studies that together provide the comparative backdrop to what you have already heard discussed by Dr. Nelson and Dr. Ghebreyesus this morning. Let me proceed to the next slide, please. We've already heard that it takes an all-of-government, all-of-society approach to solve the pandemic problem, but before that, it takes all of the world. And it is an extraordinary pleasure and honor to be presenting a study that does indeed cover enormous swaths of the world, as you see in this global map. We have studied 23 countries, 5 of them in Africa, half a dozen of them in Europe, and others in Asia and other continents. If we could see the next slide. Here you see a breakdown of the continental distribution of the countries that we have been looking at. And just a word about how we've approached this. This is not an armchair study or a set of armchair studies conducted by people sitting in one location. We've actually had teams of researchers located in all of these different places, gathering data on the spot and capturing a very volatile situation in movement. And just to give you a sense of the scope and size of this effort, if we could move to the next slide, please. So the part of it that with my colleague, Stephen Hilgartner, I've been mainly responsible for is called the Comparative COVID Response Study, Crisis Knowledge and Policy, CompCore for short. That study has involved 18 country teams led by Professor Hilgartner and myself as the 2 co-PIs, but we've been working in a leadership team composed of 5 people, including Professor Ben Hurlbut from Arizona State University, and 2 postdoctoral fellows, Onur Ozgode at Harvard and Margarita Reisberg at Cornell, without whose help we would not have been able to pull together a massive effort involving 59 collaborators in 38 research institutions. And we've been extremely fortunate to have seed money funding from the US National Science Foundation. Without that funding, the effort could not have got off the ground. And then from Schmidt Futures to carry the project forward and to expand its continental scope in the ways that you've seen. I'll now ask Dr. Wilmot James to explain a little bit about the intra-Africa studies.
So thank you very much, Sheila, and good day and good morning and good afternoon to everybody. So I led the Intra-Africa Studies review team, and we looked at 5 countries: Egypt, Ethiopia, Kenya, Nigeria, and South Africa. We had 3 co-PIs, Lyle White, Larry Stanberry, and Amanda McClelland, a research team of associates, and a review panel of 11 members. Our partners, with gratitude, resolved to save lives and the Apprentice Foundation, and we were funded by the Schmidt Futures that made the study possible. Back to you, Sheila.
Thanks, Wilmot. And if we could see the next slide. So this extraordinary team also has an enormous range of disciplinary strengths represented in it. So this is not just all of society and all of the world, but all of the social sciences, and supplemented by law, by public health and clinical expertise, by history, policy studies, and not least by my own field of science and technology studies, or STS, as well. So to the extent that we've been able to muster talent from across the university research sector and the social sciences, we've been extraordinarily fortunate, again, in being able to pull this breadth of expertise together to speak about this great public health challenge of our time. If we could move on. So let me say a little bit now about the approach and the findings, the preliminary findings of our piece of this work, the CompCore study. And let us think of it as a gateway, a door that we're opening into a set of puzzles that we were not expecting to find. So let us move on. Next slide, please. Our studies, as you've already heard, were comparative studies, and we're looking at the responses to COVID-19 across a range of nation states. So we know that this is a pandemic, and indeed it was announced to be that by the World Health Organization, and the responses in many countries shifted when the definition of the disease changed to be a pandemic. Etymologically, pandemic means that it involves indeed all of society. As we've heard, the demos is truly a worldwide demos. So then why look at the responses of nation states? And this is where I think we have to keep in mind that nations still matter. First of all, nations control their territorial borders. And the virus has shown that it has no particular respect for borders. But nevertheless, the instruments with which we try to control the virus include national measures of policy making. And across our studies, we have discovered that those national measures dominate the ways that policy is made across our 23 countries. Those national responses, moreover, themselves spill out. They travel across borders too, and they have international implications. But they land in places with very different experiences. And this is another way in which nations matter. As you'll hear from both of these studies, how nations have experienced prior disasters, including epidemic and public health disasters, has had an enormous bearing on nations' capacities to respond in this case. And those varied responses, as if in a natural lab experiment, also offer opportunities for learning. And throughout our studies, we've paid special attention to regional and cross-national similarities and differences and tried to explain where those are originating and where they're coming from. Let's move on to the next slide, please. There are some puzzles and paradoxes and divergences that have already begun to show themselves. One of them, a very important one, is the difference between the myths, the stories we tell us about ourselves, whether at the personal level or at the national level, and the realities on the ground. So I have been working in the United States, and it's extraordinary that in all formal measures of preparedness, such as the Global Health Security Index, the US ranks number one. We have the resources, we have the knowledge, we have the institutional maturity and the data. And yet the US today is leading the world in the number of deaths due to the COVID crisis. Similarly, American democracy, it's almost a cliche to say it has been a beacon to the world, and yet today many places in the world are looking with anxiety at American democracy and asking what is its fate and what is its future. When we look at the outcomes, the results are to some degree startling if one thinks comparatively. So America has almost 2,000 times as many cases as Taiwan does as of this moment. The UK has almost twice as many deaths per million people as does South Africa, even though the UK GDP is a substantial amount higher than South Africa's. If we look at the ways in which expertise is being channeled into public policy, and this is something you will hear about more tomorrow in the second half of the program, you see that countries have responded in very different ways, whether they have relied on well-established centers, as in Germany with the Robert Koch Institute, or they have put together ad hoc bodies of experts to advise them, as they have in France. And in the UK, which is a special case, there is a governmental advisory body, aptly acronymed SAGE, S-A-G-E, but the reliability or the credibility of that body has been sufficiently challenged that an independent group has sprung up, christening itself Indie SAGE, and that is offering, to some degree, counter advice to the public. And the relationship between citizens and the state is also radically different in these societies. In the Netherlands, for instance, the Prime Minister announced a so-called intelligent lockdown in which he expected citizens to some extent voluntarily to process information and to decide for themselves what course they should take. So the government gave the information, but depended on a partnership with citizens. In Japan, to some extent, by contrast, we see that the victims of disease have themselves been treated as not looking after themselves properly, and there has been a blame the victim culture to some extent. And in Singapore, we see a public that on the face of it looks compliant, but if you ask the Singapore government and its spokespersons, and indeed the public, may say that there is a great deal of trust that the state will indeed look after their interests. So you will find many details of these studies in the long report that we've presented to Schmidt Futures, and that is on the website. But let us talk a little bit further about some of the details of this study. And the next slide, please. And with that, let me hand it over to my colleague and co-PI, Steve Hilgartner, to begin the explanatory part of our study.
Thank you, Sheila. So one of the things we realized early on as we began this research is that in order to understand a nation's response to the pandemic, you can't just look at the public health system in isolation. You also have to look at the economic system and the political system, politics as a system. Because these systems are coupled and their interactions between them, problems in any one of these systems tend to spill over into the others. So this was our approach, and if we could have the next slide, please. And as we began to examine these systems, we identified 5 pieces of conventional wisdom about pandemics and public health that our studies challenge. So the first one, the first fallacy, is that a playbook can manage a plague. And our study shows the opposite. Now, the Bush and Obama administrations had developed, prior to the beginning of the COVID pandemic, of course, a playbook for addressing a pandemic. But that playbook was not followed. And a key point here is that a playbook presumes that the performers will follow their prescribed parts. A playbook only works if the key actors agree that it's the right play. And if the politics change, then players may toss the script, and that may be what happens. So that in different countries, for example, in Taiwan, they had a playbook that they had developed after SARS, and they followed that and were able to successfully address the pandemic in many respects, with actual economic growth for the year and a very low number of deaths. Germany was able to, in its economic response, use the reunification playbook and the playbook from the 2008 financial crisis to help manage its economy. In the US, the playbook was disregarded and so forth. So the second fallacy I want to talk about is in an emergency, politics takes a backseat to policy. And this is the idea that everyone will pull together if you have an emergency, that emergencies are going to produce the kinds of solidarity and cooperation. But what we find instead is that in polarized societies, emergencies amplify the pre-existing social conflicts in economic and political systems. So that in some countries, good examples being Brazil, India, and the US, you have an amplification of the crises, whereas in more consensual societies, the crises reinforce pre-existing solidarity. The third fallacy is that you can find clear indicators of success and failure, and that outcomes can be well defined and objectively measured. And our study shows the opposite. Outcome measures are always value-laden, always contested, and always erase important features of their context. The problem is that various measures of performance, and there are lots of them, are often contradictory, and experts and others all disagree about which ones may be right or important. So which indicators are important may and seem salient may change over time, and how outcomes are perceived depends on which indicators are used. So the choice of the indicators for measuring outcomes becomes a political decision and often a site of controversy. The fourth fallacy is that science advisors enable policymakers to choose the best policies. But what we find instead is that in crisis situations, technical knowledge is subject to interpretation, and the experts rarely speak with one voice. And we see this in many countries where conflicting expert advice is really the norm, not the exception. And this includes Brazil, the Netherlands, the UK, the US, and so forth. So trust in official advice correlates with trust in government. And in countries where you have higher trust in government, you have higher trust in the official expert advice. And then the final fallacy that I want to bring up is that distrust in public health advice reflects scientific illiteracy. And here we find the opposite again. There are vigorous debates about what the facts say that occur between experts, not only between experts and lay people. And this is borne out in a number of our countries, Italy, the Netherlands, the UK, the US, and so forth. And in part, this stems from the fact that as people research a moving target, estimates and models and predictions and so forth change over time. And you get overconfident expert recommendations based on evolving data, and people notice this. It's not that they're illiterate, they're often paying close attention. A second dimension of why distrust in public health doesn't reflect scientific illiteracy is that things like vaccine hesitancy may stem in part from cultural experiences with medicine. So people who have felt marginalized or exploited are going to respond in that way rather than it being merely a matter of knowledge or literacy. If I could have the next slide, please. As we sort of drilled down into this and looked at these three systems, health, economy, and politics in different countries, we found that in each of these domains, the pandemic finds weak spots in the social order. It's almost as if, just as the virus finds the pre-existing conditions in the individual body and exploits those, the pandemic finds the weak spots in the body politic. So in health, the pandemic disclosed pre-existing weaknesses, both in countries with high and with low mortality. So the United States, a high mortality country, and Singapore, a low one, illustrate this point nicely. If you could go back, to the previous slide. The United States and Singapore illustrate this. So despite impressive achievements in biomedicine and lots of planning for pandemic preparedness, the US did poorly because of structural weaknesses. For example, the lack of a health insurance system that covers all Americans, chronic underinvestment in elder care, and structural inequalities that produce vulnerability among essential workers, Black Americans, the poor, and underserved rural communities. The pandemic found these weaknesses. In Singapore, there were very few deaths, but 54,000 of the 58,000 cases in Singapore occurred among the residents of crowded so-called dormitories that house migrant workers mostly from Bangladesh and India. In the economy, the US swiftly rolled out stimulus packages, but pre-existing conditions like inequalities in wealth, income, and opportunities, and weak protections for labor left millions descending into poverty. In contrast, in Germany, emergency measures to avoid bankruptcies and layoffs were set up, and in addition, the government subsidized employers to protect jobs. So rather than, for example, putting small amounts of money into people's pockets, they subsidized employers so that the jobs would remain after the pandemic ends. They even provided this sort of income support to freelance workers in order to maintain solidarity. So music teachers and actors and other people received government support. In politics, in the US, deep partisan divisions were already well in place at the time that the pandemic came in. And you had then, within and between all levels of government, national, state, and municipal, conflict. It got to the point, as you all know, that right-wing militia members were arrested for plotting to kidnap the Michigan governor. And the government spent months fighting about a second stimulus package. In India, you also have political cleavages, and these become pre-existing conditions. So religious division gave rise to spurious claims of a Muslim plot waged through the coronavirus. If we could now switch to the next slide, and I'll hand it back to Sheila Jasanoff.
Thanks very much, Steve, for laying the groundwork. Now, this is a slide that we present with a great deal of humility because it is an interim attempt to come to grips with the very rich data collection from all of our 18 studies represented in our part of the study, and to some extent also the findings from the Africa study. But nevertheless, it is incumbent on scholars to identify some patterns, and I think we see 3 different patterns of response from the 23 nations that we have looked at in our combined studies. And we want to stress that although we're describing them here as patterns of national response, nevertheless, there are variations, there are changes and shifts over time in the pattern of a country's response. So part of the reason to put this classification out there is as an invitation to governments and to citizens themselves to think harder about why their system, their interlinked health, economic, and political systems are responding in the ways that they are. So the 3 names that we have given to these patterns are control, consensus, and chaos. And in this table, you see 3 country-by-country examples that represent, to more or less purified form, what we mean by these 3 terms: control, consensus, and chaos. So an excellent example of a control country is Taiwan. This is a country in which the threat was detected extremely early by one of those fortunate coincidences or accidents. There was a wakeful public health official who was watching the news late at night and heard about a mysterious viral outbreak in Wuhan. But since there are close connections between China and Taiwan, especially in travel, this man was able to alert his colleagues in the public health establishment. And as early as December 31st, 2019, Taiwan was able to swing into action to try to control its borders and keep the virus from coming in. Earlier on, I described the 2,000 times gap between cases in the US and cases in Taiwan. And you can say that Taiwan was extremely fortunate in being an island nation, but equally it was fortunate in having dealt with SARS and H1N1 before that, and therefore knew how to bring a public health system swinging into action when a threat arose. As a result, Taiwan did not need to lock down its economy to the extent that many Western European and American countries in the North and South have had to do or tried to do. And Taiwan today predicts a better, more positive economic future than almost every other nation included in our studies. And in the political realm, the Taiwanese public went along with their government and agreed to the public health restrictions, and you didn't see much pushback from the political side. In fact, there was approval and high approval for the incumbent party in Taiwan. Germany was far less fortunate with regard to its borders, but because the virus came in from multiple directions, one commonly given reason is that there were young people skiing in Italy where the outbreak was severe, and they came back. And by the time the disease was detected, it was already all over society. But Germany has the experience of managing public health, for it's one of the places in the modern world where the idea of a public health system even arose. But above all, under the leadership of Chancellor Merkel, Germany was able to pull together its political system, even though Germany is a federated state and there's healthy competition between regions. When the states, the Länder, as they call them in Germany, recognized that there was need for a concerted response, at least in the first wave, there was a great deal of agreement not to fight the science, but to agree on what kind of economic stimulus was needed and to agree to protect the stability of crucial employment relationships between employers and employees, which has always been a policy premium in Germany. So we call that a prime example of a consensus country where society went along with control measures that were onerous and were difficult to bear. And they have been even more difficult in the second phase over Christmas, when Germany has had to have a total lockdown. The third set of countries, exemplified by the US, but also by Brazil and India, among others, is the chaos countries. And these are the countries in which none of the three systems subjected themselves to coherence or control. So the virus spread without being checked because of a combination of factors, which you will find described in more detail in our report. The economic system suffered because, again, the structural elements of the economy, what produces the disparities and the inequalities, and the recognition that in a disaster condition, it is always the least fortunate who suffer the most. That is almost axiomatic about disasters. These things were not recognized, and therefore the economic stimulus became more a place of contestation than of coherence and coming together. And of course, about the political realm, if you were in the United States, almost the least said, the better. And with that, let me move on to the next slide. So one of the things that one can say out of this pattern of control, consensus, and chaos is that a lot depends on whether we recognize that in the face of a pandemic, the public health system enjoys what we might call a kind of sovereignty, a kind of right to control people's behavior and bodies in much the same way that a sovereign nation does. It's well to remind ourselves that this is a historical phenomenon. We have recognized public health emergencies for hundreds of years now, and we've built up a set of understandings about what is appropriate to do in the face of such emergencies. So one of these recognitions is that if there is public health, that is a communal problem, and to some extent, individual responsibilities and individual behaviors must be subordinated to some extent to the public's needs. Here you see in this image a makeshift hospital that was constructed to confront the Spanish flu epidemic of 100 years ago. And if it reminds you of scenes that you see now, it is just a reminder that we have decades upon decades, indeed centuries of experience, allowing the public health system to swing into action and to make changes in our behaviors that are accepted not just for our individual protection, but also for the common good. But just as in a political system, we give up some rights and responsibilities in order to have a peaceful coexistence, this is what we've agreed to do in the context of public health sovereignty. And that brings me to a deeper set of questions about the ways in which we as citizens live in the modern world. So if we could move to the next slide, I'll talk about that. So we see that the public health system, with its own sovereignty, has intervened in two different ways in response to the pandemic. One is by targeting the virus as almost a foreign invader. And the responses in this case all come under the heading of how to keep something out, how to erect walls and borders against an invading agent. So indeed, the first set of measures that many countries undertook were border controls, almost as if there was a physical invasion going on. And of course, the virus is a physical agent. But once the countries, most of them, not Taiwan, not New Zealand, but others, more or less lost control of the borders, the battle then moved to controlling the virus in its interactions with individual bodies. And we saw a lot of measures whose primary purpose is to keep the virus out of the body, out of people spreading the virus toward each other. And so one sees things like mask orders and things like even vaccinations as being part of a suite of measures that are still targeting the virus as a foreign invader. On the other hand, any public health person knows that transmission happens not just because of a physical agent, but because of social behaviors. So a second and interlocking suite of measures has been directed toward targeting the social practices, how we behave in relation to one another. And these include, of course, famously, social distancing, limiting the size of gatherings, requiring masks in different kinds of public and even private spaces, shutdowns of different sorts, different kinds of businesses, a redefinition of what is essential to the functioning of society, and so forth. So in the operation of these two modes of intervention, one, keeping out the virus, and two, making sure that social behavior operates in a certain way, you see the public health system doing more or less what a constitutional democracy is also entitled to do. And if we could move to the next slide. That reminds us that de facto, we in the 21st century are living in two different kinds of constitutional systems. One is the one that we're taught about in grade schools, and it goes back to documents that we call constitutions that tell us how to run elections and whom to elect and who is a legitimate representative who can represent the few, because we know that governments cannot be run by popular referendum or by populist insurrection. So we, the people, is an idea that is familiar to most of us. The idea that's less familiar is that ever since the Enlightenment and the scientific revolution, we have also been living in a representative system where we delegate knowledge authority to a very few people, the experts, whom we give the authority, epistemic authority, knowledge authority, to tell us what is reasonable to know, what is right to know under the circumstances. This is extremely important. Just as our elected decision makers cannot know everything, but they deliberate and they come to judgmental decisions about what's best, and they make compromises and trade-offs. So our delegated experts are the ones to whom we give the judgmental function to decide what is the wisest way to behave under uncertain conditions. And that in turn requires of us as citizens of 21st century nations and indeed the world to have trust in expertise. But equally, it requires the experts to make sure that they are trustworthy, that their institutions are behaving in ways that garner trust. And we'll hear much more about this from the Africa study in a minute or two. Let's go on to the next slide. So this is just to show that it is extremely important in contemporary societies for those two constitutional systems, the written one, the political constitution, and the unwritten one, the scientific and expert constitution, to be operating together. And these two images display what happens in the public health world in the face of a pandemic when those two systems are in sync. So on the left-hand side, you see an obedient social distancing that looks almost like the rows of disciplined crops that companies often show us when you've sprayed them with the right kind of spray. But on the right, you see an illustration of what my colleague, Professor Hilgartner, was talking about in Michigan, where a plot was hatched to take the governor hostage. This was a precursor to that, a demonstration in front of the Capitol. And you see that here the political system is very much out of sync with the public health system. So this is not a matter of making value judgments about one kind of political system or another. It is simply to display that the outcomes are radically different. They even look different to the photographer's eye, depending on whether people recognize or reject the idea of living in two different kinds of constitutional systems at the same time. And with that, if we could go on to the next slide. And let me now hand it over back to Wilmot James and his colleagues to describe what the findings are from the intra-Africa portion of our larger enterprise.
Thank you very much, Sheila, for that and for the wonderful background that you've sketched framing our work. Let me now take you through this metaphorical door into Africa, and we looked at the public health domain, the economic domain, and the political domain, as Stephen has pointed out, in terms of having these interlocking systems that work with one another. And to take us through the public health domain, I've asked Larry Stanberry to do that. If I can get the next slide, please. Over to you, Larry.
Thank you, Wilmot. Well, in our study, what we found were that African leaders learned from European and North American experiences and their early and aggressive implementation of public health and social measures that included masks, social distancing, lockdowns, curfews. These actions did delay the spread of SARS-CoV-2 across Africa. The public health and social measures were effective in reducing transmission, but they came at a cost. And that cost included significant impacts on the economy, on food security, and very importantly, to access to health services. The impact on access to health services is particularly concerning to us as it increases the risk of deaths due to preventable diseases such as tuberculosis, HIV, malaria, and diabetes, which I think most of us would look at when these occur in the context of a pandemic, are indirect COVID deaths. There were a number of reasons that we could detect in our study as to why there was limited access to health services, and they varied somewhat by nation. And they include closed clinics, very limited services due to staffing shortages. There were issues with lack of transportation. There was considerable differences across nations as to cost being an issue for missed health services. And then there was fear of infection. And it's pretty apparent that going forward, as the pandemic continues, it's going to be very important to address these barriers to access to health services in order to minimize deaths due to preventable causes. The other issue we were able to detect in the study was that the effect of decreased access to health services on mortality was very difficult to gauge. And one of the reasons for that was that only one country, South Africa, has the ability to measure all-cause excess mortality. All-cause excess mortality is a measure of the number of deaths which occur over and above the regular death rate. And to help guide policy and to provide more accurate estimates of the overall impact of the pandemic, it would be beneficial for nations to develop the capacity to measure all-cause excess mortality. So going forward, with regard to public health, there are important steps that need to be taken. One is going to be to better tailor the use of public health and social measures to reduce the negative impact while successfully limiting transmission. And we're seeing that play out in a number of the countries now, where using the data that are available, instead of doing a national lockdown, they'll do a regional lockdown limited curfews in a specific area. There's also going to be a need to continue to scale up testing so as to be able to better track the pandemic and to have that more fine-tuning of public health and social measure implementation. And this was touched on by Dr. Tedros, and I think we'll be hearing more of it over the next 2 days. And I suspect Dr. Fauci will touch upon this. It's going to be very important for our African leaders to learn from the Western mistakes that we see playing out right now, certainly across the United States, regarding vaccine rollout strategies. And it's important at this time to be carefully and thoughtfully developing, reviewing, and revising very comprehensive plans for the quick and efficient introduction of vaccines. As we know from what Dr. Tedros mentioned, that these vaccines will be available to African nations very shortly. So Wilmot, back to you.
Thank you, Larry. And if we can get the next slide, please. I'd like now to turn to Lyle White to review the economic impact of COVID-19 on the 5 African countries and in the wider context of Africa. Over to you, Lyle.
Good. Thank you very much, Wilmot, and thank you, Larry, for that insight into the public health side. So just as way of a kind of an overview of some of our findings and the takeaways from the economic perspective, I'm just going to highlight 4 areas that have come out from the study of the 5 African nations, and sometimes we extrapolate that into other areas of Africa. The first one, very, very importantly, the economic cost, or the so-called trade-offs, these have been particularly high for Africans. Africa as a continent and African economies will suffer its very first recession in more than 25 years. And alongside the region of Latin America, it will be the region most severely affected economically by COVID-19. COVID has represented an immediate and lasting economic impact, along with a developmental setback that by some estimates that we're seeing right now is likely to result in over a decade of lost development in Africa. We're already seeing this, as you can see from that final point, in concerns around food security, and increasingly now as we start assessing primary education in many African countries. So this is a major concern. The second very important point is that African economies they have been less equipped to withstand the stringent lockdowns that were implemented along with the upheaval of global value chains. Now, the blunt application of broad-based lockdown measures, which carried severe economic trade-offs, as I mentioned in the first point, in the interest of healthcare, were poorly understood at the time in their full extent and their prolonged impact in the African context. And this is especially when coupled with the shutting down of international markets, which African countries have become reliant on for a number of areas of export markets or capital accumulation. These have exposed clear weaknesses in the African political economy. The third point is that African economies need to be open and connected to thrive. This runs contrary to healthcare measures of lockdowns. We have seen empirical evidence, the world abound, which shows that those economies that are better connected, those economies that drive the transfer of goods, services, capital, information, and importantly, people. So it's with those countries or those economies whose citizens are connected with each other and the world, they develop and they thrive. And Africa is dependent on this. The fourth and final point is the impact and recovery across the countries covered in our study. These differ substantially. The pathways to recovery will not be even. Some will enjoy that reset, that economic reset that we have read about and seen in some parts, in some of the research, and they will modernize, while others will muddle their way through this period, which is a big concern. This diversified geography in Africa can, and we will expect to see a variable geometry in this. And one of the great concerns that I have seen is that the largest economies are not exactly leading the way in a very creative approach to the economic response. And I speak specifically then to the likes of South Africa and Nigeria. In conclusion then, and just for us to take this away, and some of as we expand the research going forward, the impact, the economic impact of this, and the numbers that have, and the outcome in Africa. The pandemic has exposed a number of issues that are in need of urgent attention. These issues include, first, the lack of reliable and accurate data in Africa. We are still, in terms of our research, our understanding, and the choices and decisions that are being made, we are relying on sometimes estimates and anecdotal evidence. Africa needs stronger numbers. The second point, very importantly, despite the growth, despite the Africa Rising narrative that we've heard so much about, the lack of crucial reforms to drive modernization of the economy and inclusive development is absent, and it's clear that we need to actually come to grips with this. And then the final point, very, very importantly, the prevalence of institutional voids and the lack of resources in and across Africa has exposed Africa's socioeconomic fragility, especially in dealing with crises like this one. So those are some of the high-level takeaways that we saw in terms of the economic impact. Over to you, Wilmot, in the next slide.
Thank you very much, Lyle, for that. Let me just say immediately that we agree when it comes to discussing governance. We agree with Francis Fukuyama that it takes a national state, not a local or regional state, not the private sector, not philanthropies, not civil society, although there are very, very important roles to play, to launch a national response. Simply because states, national states, are moral authority, they have the reach, and they have the budgets to do so. In the 5 countries we studied, all of them accepted this dictum, and all of them were led by the heads of state. Secondly, the public, though, do not trust the state. When citizens do not have trust in their states when it comes to health service delivery during an emergency, the public health community must know whom to turn to communicate risk to citizens. And countries in our study have wisely mobilized thousands of community health workers and nurses to communicate health risk messages to counteract low trust in states. Ethiopia and South Africa were particularly impressive on this front. Thirdly, leadership matters. We know this, but it matters in respect of 3 things: whether leaders acted immediately and scaled up their response, and all of them in our case studies did well. Secondly, whether they prioritized and looked after their frontline health workers and looked after their vulnerable populations. And here we must note that there were considerable health worker protests in Egypt, Nigeria, and Kenya as a measure of the problems, unresolved problems on this front. And thirdly, to ask the question whether leaders use the WHO and UNICEF protocols for the closing of reopening of schools. And here to note that we are very concerned that in all 5 countries, this is not receiving the attention it deserves. And finally, to say that multilateralism is a friend to poor countries. The Africa Center for Disease Control is unique in the world in that as a public health technical agency of the African Union, it provided the architecture for collaboration, for cooperation, and for solidarity across 55 member states of the African Union in the parts of the world that is resource stretched. The Africa CDC brought together, became the focal point for global agencies, WHO, UNICEF, and nation states and countries, and came together and brought together those who wish to upgrade their health security systems and to find the global agencies, the philanthropies in other countries who wish to support them. Our full findings are available in our report on the website, and I'd like to refer you to that. And with that, I would now like to turn it back to Sheila and to Stephen.
Next slide, please. So at this point, I want to give some key takeaway points that come from the 2 studies. Next slide, please. And these takeaway points come in the form of hard truths. And the first hard truth is that misreading the world has high costs. Our studies indicate that the field of public health as a whole has under-theorized the sociological and political terms of the actual world in which its guidance flows. The second hard truth: trust in science is not equivalent to trust in public health expertise, because public health expertise wields power over human lives and bodies that you don't have in the typical laboratory result. And third, the hard truth is that resilience is more important than planned public health guidance. Preparedness depends more on resilience than on a playbook. And our challenge is to enhance the resilience of societies and of our global order. Next slide, please. Finally, we want to acknowledge our many collaborators. I'd like to first echo Sheila's point on the leadership team members, Ben Hurlbut of Arizona State University, Oner Ozgade, and Margarita Reisberg, our postdocs. Their hard work over the holidays was amazing. And I'd like also to recognize the extraordinary talent of the 59 members of the CompCore teams who contributed enormously to this work. Their hard work and intellectual contributions made this study possible. And I'll leave it to Wilmot and Sheila to give the final acknowledgements. Next slide.
Wilmot, if you'd like to go ahead and acknowledge your support and collaborators.
Thank you very much, Sheila. To thank again Amanda McClelland, Larry Stanberry, and Lyle White, the four co-PIs, our contributing authors, the members of the review panel, our institutional partners, the Brenthers Foundation, the Resolve to Save Lives, Columbia, my home university, and to thank Schmidt Futures for their support.
Thanks very much, Wilmot. And in turn, I would like to thank Ben, Honor, and Margarita, members of our leadership team, just as Steve has done. Without them, this could not have been pulled together. I'd like to thank the NSF for its prescience in launching its rapid research support programs that can begin sponsoring researchers even while a situation is unfolding. I would like to thank the two universities that have supported Steve Hilgartner and myself, Harvard in my case, through the Harvard Kennedy School and Cornell University. And then lastly, institutions matter, but so do individuals. And we've said a lot about how playbooks are to be thrown out, but it's been an absolute pleasure to operate in accordance to one particular playbook, the one put together by Chris Kirchhoff and Barbara Bush for today's amazing lineup of activities. And we are genuinely thrilled and honored to have been playing your script for those purposes. So with that, let me bring this panel to a close and thank everybody who's participated, Wilmot and the Africa team, Steve Hilgartner, and all of the background support staff that have pulled us together so seamlessly. Thank you.